This is part 2 of special needs pregnancies, and it's going to address substance use in pregnancy. We'll start off with tobacco. The risks of tobacco include prematurity and low birth weight infants, as well as symmetrical IUGR due to the lack of flow through the placenta. Research has shown that women who smoked through their pregnancy and continue to smoke afterwards have a higher incidence of SIDS in their offspring. Pneumonias can develop through the pregnancy simply because she's smoking. Now, I posted this link on Blackboard that addresses substance use in pregnancy, so make sure you look at that. Cocaine use can cause premature labor. And the bad part about it is it oftentimes ends in abruptio placenta. So she does cocaine, she starts having intense contractions, the placenta rips away from the wall of the uterus, and no matter where in gestation she is, she's going to end up delivering the baby. It can also cause spontaneous abortions. Because it's a vasoconstrictor, it can cause intrauterine growth restriction. The fetal presentation, when under the influence of cocaine, includes tachycardia. The mother's also tachycardic. The baby can have tremors. So on looking at ultrasound, the baby can be in there trembling instead of those nice smooth movements. They can be irritable, and there's going to be a lot of increased fetal movement. Once this baby is born, there's a decreased ability to interact in their environment. They'll be poor feeders. They can have nausea, vomiting, and diarrhea. They can develop an abnormality called prune belly syndrome. You don't really have to know it, but just know that that's one of the causes of this syndrome. And then there's also decreased intellectual development. Now, alcohol is the most widely used substance in pregnancy, even though we tell people not to drink. Now, the American College of OBGYN initially said no alcohol, but knowing that people are people, they allow intermittent alcohol, but they haven't quantified exactly how much that is or how often. Believe it or not, we used to give IV alcohol, 10% alcohol IV, to stop premature labor when I was going through nursing school. In fact, the first insertion of a Foley catheter I ever did was a woman who was completely drunk from IV alcohol and was thrashing about her bed. That was a tough one. I'm glad to see we're no longer using that. So it is safe to assume that all drinking has the potential to be teratogenic to the fetus. And as you know from pediatrics, it can cause fetal alcohol syndrome. It can cause prenatal and postnatal growth restriction, and this is going to affect not only the length and the weight, but also the head circumference of the baby. There can be impairment of the central nervous system. There can be mild mental retardation. The child can end up with learning disabilities, be hyperactive, have short attention spans, as well as poor memory. And when you look at all these pictures, you can see the characteristic features of fetal alcohol syndrome. So when you look at the pictures on the bottom, on the right, you see that the fifth digit, so the pinky finger, has a bend. When you look at the ears, they have what we call railroad track ears. And then look at these children, the wide set eyes, a short palpebral fissure. They pretty much have a flat midface and a very low nasal bridge. So we need to encourage our women to not drink any alcohol whatsoever. Opiates. When tested, 3% of pregnant women have had opiates on board. Now, many women have no intention of taking these opiates because they want to be addicted. They start out with a valid reason. They had an injury, they took pain medication, and then they kind of liked it, or the pain's never gone away, so they're on it, and next thing you know, they develop a tolerance, and then after that is that addiction. You've learned that when you took your mental health class. So eventually, the use of these pain medications gets out of control. Heroin replaces the prescription drugs because all of a sudden the providers are no longer giving it to the patient. And so you know that heroin is illegal, and so there's a lot of risky behaviors that go on in order for this person to be able to get their fix on the heroin. When we take care of women who have this history of opiate, so be it the prescription drugs or the heroin, we need to screen for other drugs of abuse, and that includes the use of tobacco and alcohol. Because when they take these stimulants, they get so tired they want to come down, and so what they do is they drink alcohol to try and come down from it. We also want to ask them about other concurrent risky behaviors. Are they in an abusive relationship and their partner is holding the use of drugs or the acquisition of drugs over their head to make them stay in the relationship no matter how bad it is? Are they at risk for STDs? Are they trading their bodies for drugs? Are they homeless? Because as you know, people who have addictions have a difficult time holding a job. Are there other concomitant psychiatric issues that we're having to deal with? So what we do with these women is we try and get them off the heroin and off of the opiate. And we do this by putting them on either methadone or Suboxone. And the goal is to prevent complications of use and withdrawal. You know, when you shoot up the narcotic, they're going to be at risk for a lot of infections. We don't want to subject this baby to that. In allowing them to take these medications to prevent withdrawal, we're actually encouraging regular prenatal care. Now, they have to see a specialist in order to get these prescriptions because not everybody can write for them, although the OBGYNs can get the special privileges. It also avoids illegal or criminal behaviors that are associated with the drug culture, and that would be prostituting themselves, stealing from others so that they can pay for their drugs, etc. Now, what you need to worry about, because most of you will end up encountering these patients when they're in labor and delivery as well as postpartum. And so the issue when they're in labor is that pain is very difficult to manage because their threshold is so high for being able to take a drug and have pain relief. So their dosages are going to be increased to a level that you are not used to seeing. And so we want to encourage them to get an epidural. We don't want to give Narcan because that is going to cause an acute withdrawal syndrome. And that in and of itself can be a nightmare. So we have to be very careful on how we monitor these patients. And the anesthesia, trust me, they're going to be really watching what they're giving to the patient so that we don't end up having to give Narcan. We need to continue giving them their maintenance medications of the methadone or the Suboxone. Encourage breastfeeding because this is going to encourage the bonding and eventually change her mindset that illegal drug use is not the way to go. We continue on the methadone because, you know, we can use methadone in these babies. When they end up coming out and they're addicted, we're going to put them on methadone and eventually wean them off. And in the long run, that's what our goal is going to be for this teen or for anybody. It's not just teens who use this. And so when she takes this medication, when she's breastfeeding, it decreases the symptoms of the neonatal abstinence syndrome as well. So what is neonatal abstinence? This is a baby that is withdrawing from the narcotics that the mother has been on throughout the pregnancy. And it's exhibited by poor feeding because they have an uncoordinated sucking reflex. And you know, when we're doing our newborn exam, that's one of the things that we are going to assess. But it's going to be beyond that initial assessment. We need this baby to feed, and so we need him to get onto the breast, or we need them to get the bottle, but we have to teach them how to do it. These babies have a high-pitched cry and are extremely irritable. And they're so irritable, they don't want to be touched. This is a baby that doesn't respond to cuddling and being wrapped tightly. And so oftentimes what we end up doing is we put them in a little baby rocker or mobile type thing, and we put them in a semi-dark, quiet room by themselves. It seems cruel, but they respond best to that because this is a very difficult baby to take care of. Now, symptoms don't necessarily appear at birth. It's usually about 72 hours after birth, and it can last a few days up to several weeks. And if the baby is going to be taken away from the mother because she's deemed unfit and is going to go to a foster parent, the foster parent may not want this baby until the baby's fully withdrawn from the medication or is at least well controlled on the methadone. And so this baby may end up in the NICU for a couple of weeks. So this is the Finnegan Neonatal Abstinence Scoring System. It's one of several scoring systems that we use to determine how badly this baby is addicted. I just wanted to show it to you because people talk about it when they're caring for these babies. So this ends part 2 of special needs pregnancies.